diagnosis for the treatment of dynamic scapholunate instability. So how do we make the diagnosis of dynamic scapholunate instability? The history is the first clue. A high impact on the hand when you fall or trauma using a high torque drill. There is no diagnostic examination for this diagnosis. The best you have is perilunate tenderness and pain and clinical suspicion. Functional x-rays may or may not help. An MRI may or may not help. A hand upper limb evaluation using dynamometers can be of a great assistance. An arthroscopy, taken in conjunction with a history examination, the x-rays, MRI, and the hand evaluation, is the key to making the diagnosis. So if you look at the key factors, examination with perilunate tenderness, a hand upper limb evaluation, which looks at the power in the hand using a JMAR for growth grip, lateral pinch, and most importantly the force plate, how much force you can place on the dorsiflexed wrist when weight bearing, supination strength and pronation strength. You look at the range of motion, the active range of motion in the wrist, and the function using a dash PRW with scale at rest and with use. Arthroscopy will demonstrate the scaphoid opening up from the lunate dynamically. And when you take the traction off, this increases and you can drive right in, and there you can see the scapholunate ligament. In most cases, the scapholunate ligament is intact. It's actually an extrinsic ligament injury. Now, Christoph Matulin introduced us to the concept of arthroscopic repair of scapholunate ligaments and described dorsal capsuloscapholunate septum as part of the mechanism that needed to be repaired. Again, in my opinion, it's essentially an extrinsic ligament injury, and it's only when it gets more severe that the scaphoid ligament is completely torn. Max Harley elaborated and evolved the technique to emphasize the importance of not trying to repair the scapholunate ligament, but to take a bigger bite on the dorsum to get more tissue into the repair. It's important, in my opinion, to scope the entire wrist and the DIUJ. You need all the information. If you make a decision on an incomplete information base, you may not get the answer or the result that you're looking for. So I'm going to show you the technique that I use to do a dorsal scapholunate capsulodesis. I use a dry technique, and I get as much of the dorsal extrinsic ligaments as I can. Here I'm debriding the dorsum of the scapholunate joint so I can see when I pass a needle, and I've bent the needle, curved the needle to make it easier to get into the midcarpal joint. I can see the needle pass over the top of the scaphoid, and you can see I'm aiming radially to get as much of a bite as I can. You can actually see where the needle has gone in. It's not done blind. Then we can look in the ulnar midcarpal joint to find the needle and the suture. And you can see how it's pointing radially. That's the scaphoid below it in the capitate, and there's the scapholunate joint. Now I've taken it right across and then brought the needle down into the midcarpal joint to make it easier to retrieve. Then go back into the 5-6 portal, look across, and then pass the suture through the top of the lunate. And again, you can see the curved needle moving up the lunate, over the edge of the lunate, and you can actually see and feel it going to the midcarpal joint. This shouldn't be forced. If you're in the right plan and you have the right technique, you should feel it pop into the midcarpal joint. And it varies from joint to joints, and also how much instability is present. Going back into the ulnar midcarpal joint to retrieve the suture. And what you can see here is a wide grasp of dorsal tissue. You see the scaphoid, the lunate, and I'm right over the triquetral-lunate joint. That's the scapholunate joint you can see there, and the capitate on the top of the view. There you can see the wide band of tissue I've caught with a dorsal suture. From radial to the scapholunate joint to ulnar to the triquetral-lunate joint. See the lunate there, so you can see I've spanned the entire lunate. And then when I pull on the suture, you can see it reduce. The scaphoid being reduced onto the lunate. And then it's a simple matter of tying the suture. So that was a straightforward dorsal scapholunate capsulodesis for dynamic scapholunate instability with a drive-in sign without a drive-through sign, the scaphoid and the lunate opening up and the easy passage of a 1.9 scope into the joint. What I'm going to share with you now is a drive-through sign with slight dorsal subluxation of the proximal pole of the scaphoid. And again, here is a needle inserted into the 3-4 portal. And here you can see the scaphoid on the right, the lunate, a tear in the scapholunate ligament, the radioscapholunate ligaments, and you can see the tear from the radiocarpal surface, which means that this is a significant tear. And up here you can see a small defect in the articular cartilage of the proximal pole of the scaphoid. There's no defect on the dorsal rim of the scaphoid fossa of the radius. Here's a triangular fibre cartilage with a positive ghost sign. And many of these injuries to the triangular fibre cartilage, when there's a dorsal peripheral tear, will have a small tear at the radial insertion of the triangular fibre cartilage. Use another obturator to insert the scope to evaluate the foveal insertion. Instrumenting through the palmar distal radial ulnar joint portal, the foveal insertion is debrided. And once it can be seen, a probe is inserted and the integrity of the foveal insertion evaluated. And here you can see there's a good foveal insertion, it's strong and it's intact. So we know we don't need to repair the foveal insertion, we need to repair the dorsal peripheral tear of the triangular fibre cartilage. This is standard triangular fibre cartilage repair, as Toshi Nakamura has described, using a double-stranded 2/0 viracle. Now you might ask, why am I talking about the triangular fibre cartilage when we're talking about dynamic scapholunate instability? Well, it's important to examine the entire wrist, because approximately 30% of people with scapholunate instability will have a significant tear at the triangular fibre cartilage, because the wrist is a circle that moves through time in 4 dimensions. So here's a double strand of vicryl on the dorsal part of the triangular fibre cartilage, repairing the dorsal distal peripheral tear. So now we're going to look into the radial midcarpal joint. And what we can see here is the scaphoid. We look into the triscaphoid joint, we can see the trapezium and the trapezoid coming across. You can see the scaphoid skipping across to the triquetral-lunate joint, and then the scapholunate joint. And that's a wide drive-through sign. And there's the scaphoid fossa, and we can go backwards and forwards between the midcarpal joint and the radiocarpal joint, and the scaphoid and the lunate dissociate, and they're very lax. Now this is a scapholunate dissociation that we could appreciate on an MRI scan, and there's slight dorsal subluxation of the proximal pole. So inserting the scope into the 6R portal, the first thing is to examine the ulnar side of the joint. There's the scaphoid fossa, scapholunate joint. Coming across, we can see the triangular fibre cartilage lunate ligament. The triangular fibre cartilage triquetral ligament. That's where the triquetral lunate ligament is. There's no tear, and into the pisiform recess. Here's the pisiform, and I'll put a needle into the pisiform so I can gain access to the pisiform triquetral joint to ensure there's no pathology in the pisiform triquetral joint. And again, I make no excuse, it's very important to examine the entire wrist, because I'll emphasize it again, most significant scapholunate injuries have got a problem in the ulnar side of the wrist. You see the triquetral-lunate ligament. Now we're back across to the proximal pole of the scaphoid, and there's a small area of full thickness cartilaginous loss. It's only small. And the next thing is going to be to debride the soft tissue on the dorsum of the scapholunate ligament. This is all done dry, so you can see the proximal pole with a small defect in the cartilage and the tear of the scapholunate ligament. You can see how it's torn, and dorsally you can see the gap between the scaphoid and the lunate. The next step is to pass a suture. There's the scapholunate ligament under the gap between the scapholunate ligament, across the top of the scaphoid and the midcarpal joint, and you can see how I'm aiming radially to get as much soft tissue as I can grasp with that suture passage. So it's hard to get in between the scaphoid and the capitate because the scaphoid's palmaflexed. So if you put a needle into the scaphoid, you can mobilize it, and then you can pass your needle into the gap between the two. Just park it on the top, and when you've got it free, pass the needle through. Retrieve your suture, usually with a mosquito, but sometimes a 2mm grasp is invaluable. Now we're going to pass the suture over the top of the lunate. And you can see the scapholunate ligament, so you head only over the top of the lunate. Feel your way over and make sure that you're getting a good bite of tissue on top of the lunate, and then penetrate the midcarpal joint. Then back into the ulnar midcarpal joint to retrieve the suture. And then we can pass the double-stranded 2/0 vicryl. You pull on it and you can reduce the scapholunate joint. It's a matter of just tying the suture. Post-operatively, a below-elbow splint for 6 weeks. A wrist proprioceptive exercise program from week 6 to week 12. Now, for isolated scapholunate instability, over a 12-month period, I treated 59 scapholunate instabilities, and of that 59, only 8 were isolated. All the other injuries and additional injuries. So looking at these 8 isolated dynamic scapholunate instabilities, which was 13.5% of our entire scapholunate ligament repair for that 12 months, we noticed the following. The range of motion compared to the contralateral uninjured limb at 3 months was decreased. At 6 months, it was back above the pre-surgical range of motion. But the most profound one was radial deviation. You can see how that improved over 6 months and up to 12 months. The dynamometers, again at 3 months, were reduced compared to the preoperative assessment, but they'd regained their strength and had continued to improve at 6 months. So what we're seeing is that it took 6 months to regain the power in the upper limb. And perhaps the most important reading is the force plate, the ability to weight bear on the dorsiflexed wrist. And that's down at 3 months, and 6 to 12 months it increases, and it's much stronger than what it was before the surgery. So dynamic scapholunate instability, drive-in or drive-through. My preference is arthroscopic dorsal scapholunate capsulodesis. Thank you.